Hey everyone, welcome to this high-yield explainer. Look, if you're gearing up for your fixed prosthesis board exams right now, you are in exactly the right place. Just think of this as your masterclass study guide. We're going to take all those dense, complex, clinical textbook concepts and distill them down into the precise, highly testable facts you need to absolutely dominate your exams and, actually excel in the clinic too. All right, let's dive right in.
Now, I know the word failure can instantly trigger a ton of anxiety, especially when we're talking about a clinical setting. But honestly, remember the old saying, failure defeats losers, but it inspires winners. We really need to reframe that anxiety right out of the gate. Taking the time to analyze clinical mistakes in a safe, structured space like this, well, that's exactly how we learn. Truly understanding why a prosthesis fails is the master key to making sure yours actually succeed, both on test day and, more importantly, with your future patients.
So here's our roadmap for today's explainer. We'll start with defining clinical failure, then move into faults and failure types, patient symptoms and complaints, the biggest culprit, caries, trauma and perforations, and finally a material spotlight on MTA.
All right, Section 1, Defining Clinical Failure, Establishing the Baseline. The absolute most crucial thing to grasp here is that a failure isn't always going to be as blindingly obvious as, say, a bridge completely snapping in half. By its very definition, failure is just a general term implying a part in service has met one of several specific conditions. Board exams absolutely love to test the technical boundaries of this definition, so you've got to remember that a prosthesis definitely does not have to be totally broken into pieces to be classified as a clinical failure. Let's break that down into the three distinct states you really need to memorize. First up, we have completely inoperable. That's the obvious one, right? Second is operable but inadequate. This means it's technically still sitting there in the mouth, but it's just not doing its intended job anymore. And third, it's deteriorated to the point of being totally unreliable or unsafe. Now listen closely, watch out for trick questions that try to distinguish between completely inoperable and operable but inadequate. Don't let them fool you, they are both firmly classified as failures.
Moving on to Section 2, Faults and Failure Types, breaking down the errors.
Okay, you absolutely must understand the technical distinction between a fault and a failure. A fault is strictly defined as an incorrect step or process. A failure, on the other hand, is the result of that fault. So think of it this way. The fault is the action, the mistake itself, while the failure is the actual clinical consequence that you're looking at in the patient's mouth.
What's kind of fascinating and a bit scary about the clinical timeline is that testable errors can happen at literally any stage of treatment. We've got 5 main sources of faults to track: improper case selection, improper diagnosis and treatment planning, inaccurate clinical procedures, inaccurate laboratory procedures, and lastly, insufficient post-insertion care and maintenance. Basically, as a clinician, your vigilance has to be dialed in from that very first consultation all the way through to the follow-up visits. The whole shebang.
And when those procedural faults occur, they inevitably manifest as failures. A great study hack here is to mentally categorize every single clinical failure you study into one of these 3 major buckets: biological failures, mechanical failures, or aesthetic failures. Building this mental framework early on is a real game changer. It'll help you rapidly eliminate wrong answers on those tricky multiple choice questions.
Section 3, Patient Symptoms and Complaints, the Clinical Presentation. Now let's get real for a second. When a patient sits in your chair with a failing prosthesis, they are not going to use textbook terminology. They're going to report common, everyday complaints like pain or sensitivity to cold and sweet stuff, a bad taste or bad breath, a loose restoration, they might be unhappy with how it looks, or they'll point out redness, bleeding gums, or even a periodontal pocket and abscess. Notice how certain symptoms, like sweet sensitivity, bleeding gingiva, or a lingering bad taste, almost always point directly back to those underlying biological failures we just talked about.
Oh, pulp pain. This is a massive, highly tested topic on the boards. You need to look closely at these clinical distractors. Causes can include overheating or dehydrating the dentine, overreduction during prep, inadequate caries treatment, a tiny, minute, unnoticed pulp exposure, inadequate protection of the prepared tooth, using a really irritating luting agent, or even a low-grade pulp infection that suddenly gets activated by traumatic occlusion. The takeaway here, seemingly minor errors, like just overdrawing the dentine with an air syringe, can trigger severe, undeniable pain for the patient.
Section 4, the biggest culprit, caries, high-yield statistics.
I need you to literally burn this number into your memory right now.
36%. Caries represents an overwhelming 36% of the frequent causes of failure in fixed prosthodontics. Seriously, if you're ever completely blanking on a board question about the most common cause of biologic failure for fixed bridge, 36% of the time, the answer is just going to be caries.
And speaking of exams, here is a classic, sneaky distractor I want to explicitly warn you about. A major study proved that the incidence of caries is actually not related to the age of the patient. Let me say that again so it sticks. It is not related to the patient's age. Instead, caries incidence is directly related to the amount of time the bridge has functioned in the mouth. The longer the prosthesis is in service, the higher the risk becomes. Please, do not fall for the elderly patient trap on your exams.
Okay, let's connect the clinical dots here. Why are these caries happening in the first place? Almost always, it comes down to faulty margins. Whether the margin is left open, it's cut short, or it's overextended, that physical gap leads directly to the dissolution of your luting cement. Once that cement starts washing out, microleakage kicks in, which basically creates a 5-star resort for decay. Other major causes include the incomplete removal of caries during your initial prep or a loose retainer that just lets all the bacteria flood right in.
Moving right along to Section 5, Trauma and Perforations, Mechanical and Iatrogenic Damage.
First up, we need a crystal clear definition of traumatic occlusion. It's essentially an injury to the periodontal tissue in the pulp of a tooth caused directly by occlusal forces from an opposing tooth or teeth. You really have to visualize this mechanism. The biting force from the opposing arch is literally driving trauma straight down into the periodontium and right into the pulp chamber. It's like a tiny repetitive hammer blow.
Now pay very close attention to the term premature contact. Premature contact and centric or eccentric occlusion is the absolute main culprit here. And what exactly does it lead to? 3 highly testable outcomes you need to know: excessive tooth mobility, pulp damage, and TMJ disorders. So if an exam question ever mentions a patient complaining that their brand new bridge feels high and then they start experiencing tooth mobility, well, you know exactly what biological cascade is happening.
Notice how the instruments or posts here have completely breached the boundaries of the root canal system. This kind of error entirely compromises the foundation of the prosthesis. If you're a visual learner, it is absolutely essential to connect the textbook definition of iatrogenic damage to the actual real-life radiographic presentation. Once you see it, you'll never unsee it.
So what actually causes these devastating perforations? There are 3 primary iatrogenic errors you have to commit to memory because they are prime fodder for multiple choice questions. They are improperly located pinholes or pins, improper endodontic treatment, and improper post-preparation. In these procedures, precision is quite literally everything. Being just 1 millimeter off during a post-prep can easily mean the complete loss of the tooth.
Finally, Section 6, Material Spotlight, MTA, Microscopic Material Facts.
MTA, or mineral trioxide aggregate, is basically a miracle material in the clinic, if you know how to use it right. You absolutely must memorize its composition for the boards. It's a compound mixture of hydrophilic, tricalcium silicate, tricalcium oxide, and tricalcium aluminate. Let me really highlight that phrase for you: hydrophilic tricalcium silicate. Also, remember its totally unique setting property. Unlike almost every other material we use, MTA actually requires and sets in a moist environment, which, let's be honest, is wildly ironic considering you're going to spend 90% of your dental career aggressively fighting saliva and begging for a totally dry field. But for MTA, moisture is its absolute best friend. And once it's fully set, it has incredibly low solubility, which makes it absolutely perfect for repairing those root perforations we were just looking at.
All right, we've covered the definitions, the crazy statistics, the mechanical failures, and the material science. So I want to leave you with a final, slightly provocative challenge. Think about this. If 36% of all failures are caused by caries, and we know that caries largely come from faulty margins, is the true root of clinical failure the material itself, or is it actually our own hands during that initial prep? Definitely something to chew on before your next clinical rotation. Thank you so much for joining me in this explainer. Keep studying hard, and I'll see you next time.